request Dr. Meghna Roy, Surgical Management of Pterygium. Is Dr. Nilima here? Okay, then this is the last talk for the session.
Good morning, everyone. I would like to thank AIOC for giving me the opportunity. My topic is on pterygium, and it's a very basic topic on the management of pterygium. So we all know that pterygium is basically a wing-shaped elastotic degeneration of the subconjunctival tissue, and it has got a worldwide distribution, but it is more common in warm and dry climate, and mostly it's in the tropical areas the prevalence is as high as 22%. So these are the various types of pterygium. Basically it is on the nasal side but can also occur temporally. They can be double pterygium, atrophic pterygium, and as the visual axis is obscured, it can lead to cosmetic intolerance as well as diminution of vision. So the patient has these basic symptoms of foreign body sensation and diplopia and irritation.
Dr. Dipti, sorry to interrupt. You can straight away go to the presentation for the dearth of time.
Coming to the grading of the pterygium, according to TAN's classification, grade 1 extends 2 mm on the cornea, grade 2 involves 4 mm of the cornea, which can be, when it encroaches more than 4 mm of the cornea, it can hamper the visual axis. So according to the visibility of the episcleral vessels, it can be grade 1, grade 2, or grade 3. In grade 3, there is total obscuration of the episcleral vessels under the pterygium. So the treatment can be either conservative or surgical. So coming directly to the ocular surface transplantation procedures, conjunctival autografting, rotational autograft, conjunctival limbal autograft, and amniotic membrane grafting are the transplantation procedures done. So in conjunctival autograft, mainly the autologous free conjunctival graft is obtained from the superior bulbar conjunctiva of the same or opposite eye. It is the gold standard in surgery. And according to the clinical study of Fernandez et al., an analysis of pterygium outcome after 14 years, it has been seen that CAG is an effective modality for both primary and recurrent pterygium, and the Bayer sclera technique has unacceptably high recurrence rate. So why CAU? Because it has excellent cosmesis and low rate of recurrence, and but there are certain risks of MMC which need some long-term studies. So the recurrence rates in conjunctival autograft is 12.2%, whereas in Bayer sclera is 19.4%, and Bayer sclera with mitomycin C is up to 38%. So this is the preoperative management, in which the history is important along with the occupational history, and the routine investigations are done. So the head of the pterygium is first avulsed from the cornea in the centrifugal manner, and it is scraped with a 15-number knife or crescent blade, and then the subconjunctival tenons is separated. The head of the pterygium is cut and hemostasis is achieved. The conjunctival autograft is taken from the superior aspect, it is rotated and placed on the Bayer sclera. The graft is then sutured with the conjunctiva with sutures, and bandage is done. So amniotic membrane transplantation is also done. It is a little costly, but it reduces the time and it has less amount of vascularization, and in case of large defects, we can use this. So if the surgery is done with the help of amniotic fibrin glue, then the preparation of the glue is done prior to the surgery, and the post-op regime mainly includes the topical steroids, antibiotics, and tear substitutes. So these are the various complications. Graft edema can occur along with Dellin formation or conjunctival granuloma formation, inclusion cysts, graft inversion, and necrosis. And late post-operative complications include scarring at the site, steroid-induced hypertension, astigmatism, and sometimes necrotizing scleritis, which is surgically induced, can also occur, which is although very, very rare. So nowadays, the role of 2% lidocaine gel in pterygium surgery is also used, because it is given 5 minutes before the surgery and in the conjunctival fornix, and every 10 minutes during the surgery. And there is sustained effect of this drug due to longer contact time with the ocular surface, which is beneficial for the cornea. The adjunctive therapy for surgical intervention include mitomycin C thiotepa, which is nitrogen mustard alkylating agent, and it reduces fibroblastic activity and also reduces mitosis is arrested. 5-FU corticosteroids, which reduce the inflammation, interferon alpha, which is also used in conjunctival intraepithelial neoplasia, along with beta irradiation, which again reduces the mitosis, and cyclosporine, zoledine and bevacizumab are the adjunctive therapy which can be used along with the excision of the pterygium. So in case of recurrent pterygium, firstly, after the recurrence, we have to wait for at least 6 to 8 weeks, 6 to 8 months before operating, because there is a lot of inflammation and scarring. So these are the various methods for the management of recurrent pterygium. And current modalities include laser, photodynamic therapy, irradiation with 32P source, and concavalin A. Concavalin A is basically used to detect the recurrence in the pterygium by recognition of the remnant tissues of the pterygium by combining with fluorescent and instilling it in the lower fornix, and then with a lamp we can actually recognize the remnant tissues which are there and the stretch marks which are present on the cornea. And these are the medicines: curcumin, tacrolimus, nitric oxide, and superoxide dismutase, and recombinant growth factors, which are still under study. This role of curcumin in the human pterygial tissues and its role in reducing the mitosis and fibroblastic proliferation is seen, and around a dose of 20 millimole if administered 15 to 72 hours post-operatively, it has been seen in the studies that there has been reduction in the recurrence of pterygium. Thank you.
Thank you, Dr. Meghna. Are there any questions?
I would like to ask one. So what is your experience with autologous blood for sticking the graft?
Yes, ma'am, it's an excellent method we are using these days, and instead of using glue or even using the sutures, we are using autologous blood, and after carefully placing the graft, we are able to see that it has got good results, even in the CAM patients.
So that is your cost with the glue increases. It is costing, TISIL is almost costing around 10,000.
Yes, ma'am.
So if you use autologous blood, then the graft also stays well, and you can reduce the cost to the patient.
Yes,
also. You can put BCL over it for some time so that it gives a good pressure kind of thing. Okay.
Yes, ma'am.
So that is one thing which you can improve upon in your
Incorporate, yes, ma'am.
surgical techniques. Yeah.
Thank you, ma'am.
Thank you.